Hello. Hello.
Yes.
Sir, you are connected.
So this is the area where we have. This is the area of the bladder neck, and that's the. So we are about to finish the right side, and then we'll be proceeding towards the left side. The left lobe is now taking first, and then the. So this is the entire floor, and so these are the capsules, and somewhat oozing gland.
For the chairpersons of this session, now I will request Dr. P.N. Dogra to come on the stage and felicitate the chairpersons. Sir, please. Professor Mohammed Salim Wani.
इसका ना थोड़ा पानी में
Sir,
निकाल के
please.
एक बार वो करना. ये लाइट चली गई है. What happened? Yes, source वाले.
Dr. Umar Salim.
On the screen. ये स्क्रीन बंद हो गया.
Dr. Yasir Ahmed.
हेलो. सोर्स वाला बंदा कहाँ गया? यार ये ना स्क्रीन आपका ऐसे हो गया. देखो जरा.
Thank you, sir. Now I will request the chairpersons for the next session. Dr. Sajad Ahmed Parra. Of course, this is the last session of the day. Dr. Sajad Ahmed Parra, please.
यार पीछे से मत जाओ उधर से ना.
And Dr. Fawad.
मैडम वो
Kindly come on the dais and chair the session.
लाइट चलाओ.
And Dr. Saqib Mahdi, please come on the dais and chair the session. This will be the last session of the day. Kindly proceed towards the dais.
वहाँ पे ना वो उन्होंने टेप से लगाया था, तो वहाँ पे किसी को बिठाना नहीं है, मना कर दो।
Dr. Ashish.
So there is no light.
Hello?
Actually, the light source has
Dr.
stopped.
Ashish.
Yes, sir. Actually, we are just fixing the light from the light source. Yes.
Ashish sir,
Yes, sir.
Yeah, your beam.
Actually, we were just fixing the light now. The light source was off. Now you can see.
Right. Okay. Okay. Because we were getting a very bright beam, that's why. Okay. Which oscillator you use?
I'll be using a bio-red oscillator. So basically, it is just like the wolf piranha, and with the same action. And usually, it's a to and fro motion. So it is a bit faster, and so I have been using the same at my center. So we'll be using the same oscillator.
Yeah, we have the same oscillator for you. And how long after you change the blades?
How long?
How many uses the blades need to be changed?
Sir, usually even 50 cases, single blade.
Okay. And if your oscillator suddenly goes bad, then what do? It's not working one fine morning, and you have a list of cases that.
यहाँ पे थोड़ा सा मुझे ना प्रेशर चाहिए. Some bleeder from the. पंपर है यार यहाँ पे एक.
Saini sir, hello. Saini sir, am I audible?
Yes, yes.
Dr. Fuad here. Just for the sake of audience, can we do it without a oscillator like what has been mentioned as the mushroom technique? And like Khan sir just said, if the oscillator just by any means goes down, and can we use some other technique, or we just have to get another one?
See, basically, you can do the mushrooming, but then better to buy a oscillator. You can, for people who are just trying to learn, and everybody is in a learning process. So you can create a groove at 5 and 7, and then you can do the mushrooming. Because what happens is that it starts to flip flop after a certain point of time. So that is an issue.
Right.
So it was a large gland and a lot of big bleeders.
So we can appreciate that. It was a commendable job what you're doing.
यार पानी को बंद नहीं करो भैया, ध्यान दो. नहीं ऑन कर दो ना ये. यार एक बंदे को ना यहीं पे खड़ा करके ना पानी के लिए कर. दिस ट्रबलसम लीडर है यार यहाँ पे एक ना, इसको हमें करना पड़ेगा। थोड़ा पानी चाहिए यहाँ पे ना, मेरे को ना इधर प्रेस करना है जो भी होगा ना। So whenever there is a bleeding, you can reorientate yourself. Let the adenoma fall on the bleeding and take care of it for some time, and then you can restart. So that way, sometimes it may be helpful. इसको इंक्रीज कर देते हैं, लेट अस इंक्रीज द एनर्जी 220 करो। रेडी रेडी करो।
Thank you, sir.
Dr. Ashish,
Yes.
can you tell the audience the ways to manage bleeding in these lasers?
Usually I never face bleeding issue with this thulium, but sometimes if you go too deep, then yes, you may encounter those bleeders. So this is what we are encountering at that point of time. Usually what you can do is, it doesn't need a defocus. It has a dual pedal, so you can just fire it, just like a coagulation, and it will stop. A bigger bleeder will be an issue. So better to let the adenoma fall on the bleeding and wait for some time, and then you can come back. So this is what we are trying to do. The other thing is that the irrigation, sometimes the people are too much, you have to look at whether there is an inflow or not, and people are too much engrossed in the surgery, so they may forget that the bottle is empty. So if there is a bleeding, first of all see whether the irrigation is there or not, and once it is there, then in Holmium you can defocus. In this you can just have a setting. So I have a setting of 0.2 joules and 150, so that's 30 watt for the coagulation.
Thank you, sir. Just for the sake of discussion, would like to have your opinion about the green light laser in this contemporary era with specific indications in patients with, what is the role? Is there any role, or thulium has just replaced it?
So green light laser per se can be used for people who are, I don't know, it has not been popular in India because of the cost. The other thing is that the post-op patients have a lot of dysuria. So that is a problem always with a green light laser, and that will remain because we are vaporizing only, we are not enucleating. My personal experience is that the patients are not happy per se when a green light is used.
So in patients with coagulopathies or cardiovascular disorders who are on anticoagulants, so what would be your first choice?
Sir, we can do enucleation in patients who are even on anticoagulation. So the clopidogrel needs to be stopped. You can continue aspirin.
Right, sir.
Sometimes it all depends upon the gland, how vascular the gland is. Sometimes you may not even have a drop of blood in a patient who is on anticoagulants, and sometimes a normal patient who has an oozy prostate may bleed.
Right, sir. Because in guidelines, it is still a viable option for a gland size of 30 to 80 grams. It's still in guidelines, although it may be out of favor, but in guidelines it's still mentioned
No,
that.
still if you look at the papers, then in US,
Yeah.
majority of the time people are now doing Eurolift. The TURB is still the most common. Holmium or Holab, since it has a curve which is there for a very long time, it is still not popular. Very few people are still doing it. So things are moving ahead for India where people are shifting to enucleation. And otherwise, green light laser has been popular in the US because of other factors and because of the ease to do it. But per se, it may not be that great looking at the current lasers which we have.
Right, sir. Thank you.
So when during a procedure for a beginner who is still in his learning curve, should he convert to a standard URP once he is on the journey of learning a new creation?
See, at URP also has a learning curve. So yes, for people who have to start, you have to first start the URP. In a learning process, you just can do the median lobe initially.
Right.
And once the median lobe, you have done around 10-20 median lobes, then you can start with one lobe. The other you can resect. And then you can wait for your morcinator to come and then complete the job after, once you have the entire armamentarium. Something like that.
Thank you.
They're still not able to fix that bleeding. And most likely will not be.
Seems to be a very vascular prostate.
For a conference, 120 gram prostate is a big task. I think if you are trying to learn, then 60 gram is good, because sometimes the people may feel that they may not even venture into it after seeing it. So it may be discouraging. So I think, yes, ideally a 60 gram should be the choice to show it properly.
Is because the prostate is a nodular disease. At places there are multiple nodules where the capsule is thin, where you are difficult to appreciate the capsule properly, and you go little deeper also, and that also lead to bleeding.
Yes. So most important is that you reorient yourself, that you should come from a known plane to an unknown plane. So If you are in trouble, always the bladder neck is your landmark. Just come back, fall to it, and then again start. So it's a game of perseverance. And
So there's a famous quote by a famous man, Sun Tzu, patience is the art of war.
yeah. Patient is okay, ma'am. Para o koy dedi kayal paknas. Paknas okay. One can see the vessels
Yes, sir, we can.
and you can easily coagulate it. See, this is a vessel and you can just coagulate it. Not able to find that holy grail, yeah, come on. So, I'm still not able to find that holy grail. Yeah. So one can see that these are all the capsular fibers and
Yes, sir, we can see very clearly.
चले ना भैया।
Board gland reference, board gland highly vascular. En esas fikri kormutum.
Come on, that's not getting detached. Yes,
So, what is the incontinence rate in after doing this toilet?
sir, incontinence rate is way less, sir.
Okay.
Way less.
So, what are the tips
So
to?
even if, in my personal experience, I haven't come across somebody who is incontinent after a period of 1 month.
Okay.
So that is something which is really reassuring, because the only problem with Holmium was that people had incontinence.
Definitely, yeah.
And that's the reason that this thing never became popular. People may deny it, but most of the studies which were done were how to decrease the incontinence. And a study is always done when there is something
Wrong,
which is
yeah.
causing it.
Exactly.
So it is self-explanatory that incontinence was always there.
Yeah. So how to prevent it? What are the tips if
See, you
you...
need to first of all release the apex upfront as we have released in this case.
Exactly.
Some people try to push a lot, especially when they are doing the gland. So when you are trying to push, a mechanical push can cause a lot of trouble, especially with the resectoscope, which has a hood-like thing.
Okay.
So that way, that is something which should be avoided. And
He said,
See, once we do a TRP, especially when I do a TRP, I just keep some of the gland just near the apex. Once the tulips start, they start from that area to lift the apical tissue, and then go into the blade.
फिर भी नहीं हो रहा है ये तो. Okay, everything is okay. हाँ हाँ ठीक कोई दिक्कत नहीं. ठीक ठीक है ठीक है.
Sir, in larger glands with larger resection time, do you see higher structure rate, or there's nothing like that? So there's no association.
See, if you are not dilating it properly, and if you are using a force, then yes. Otherwise,
Right.
Sir, do you use Otis urethrotom or simple dilators for calibration? Hello?
yes.
Sir, do you use Otis urethrotom or simple dilator for calibration?
I don't use a dilator at all.
he said, sir, if we have an inadvertent, we are in the wrong plane and there's a perforation, a large enough perforation. So how do you go about that, sir?
See, if there is a marginal perforation, then then you can do a suprapubic diversion, and you can continue. Otherwise, you have to come back.
Right, sir.
And so many people are seeing it means कि मैं थोड़ा लेट कर रहा हूँ. इतने सारे लोग देख रहे हैं कि मैं लेट कर रहा हूँ. नहीं नहीं सर आप Can't do anything here. Continue.
No, it is a big gland, we know that. You are doing absolutely a fine, wonderful job. So this is at the bladder neck you are setting to drop this into the bladder.
Right, I think, yeah.